Hello guys, we've already looked into acute hepatitis B. So today we'll look into what is chronic hepatitis B. The chronic hepatitis B, it is symptomatic, biochemical or serological evidence of hepatitis for more than 6 months will become chronic hepatitis B. So the acute hepatitis B, most of the patients will resolve at acute stage, whereas 1 to 10% of patients may develop this chronic hepatitis B. This acute hepatitis B can develop into chronic hepatitis B, which can further develop into cirrhosis and hepatocellular carcinoma. Let's look at the phases of acute hepatitis, chronic hepatitis B virus. The phases of chronic hepatitis B include immune tolerant phase, immune active phase, inactive chronic phase, and chronic HBsAg negative immune reaction. So initially, if the infection occurs in children or newborns, the newborns will be tolerant to the infection. That is, the HBeAg and the HBsAg will be positive from the childhood itself. Therefore, there will be no immunogenic reaction, and the HBV DNA will be very high. That is, the virus is replicating actively, but the child is asymptomatic and the LFTs are normal. The liver biopsy is also normal, and this phase will last for decades. And next will be immune active phase. So now the body knows that there's something wrong with the body and therefore starts generating an immune reaction. So in response to this immune reaction, the patient will become symptomatic. The HBsAg will be positive, the HBeAg will be positive, the HBV DNA will be high. The virus is replicating, and there's also symptoms, that is elevated ALT and AST, and in this ALT will be more than AST. The liver biopsy will show inflammation, necrosis, and fibrosis. And next phase is inactive chronic hepatitis B, or the carrier phase, which is generally seen in adolescents and adults. This carrier phase is with less replication. That is, the HBsAg is positive, but HBeAg is negative, but HBe antibody is positive. Anti-HBe antibody is positive. That means the infectivity is reduced to a great extent in these patients. Since HBeAg indicates the infectivity is reduced in these patients. The HBV DNA will be low or undetectable. The ALT is normal and liver biopsy shows no significant hepatitis. Chronic hepatitis E antigen negative immune reaction. In this phase, there are mutations of production of HBe antigen, or there is low HBe antigen. So even though the HBe antigen is low, the HBV DNA is high. So why is the HBe antigen low? Because there is mutation production of HBe antigen. Therefore, the HBe antigen, in spite of the viral replication, will be low in these patients. But the HBV DNA is high. That also indicates increased replication of the virus and active infection. So in this phase, there is reactivation of the chronic infection, and the liver enzymes will be elevated. The liver biopsy will show inflammation and fibrosis. There is increased risk of hepatocellular carcinoma and cirrhosis. The clinical features: the patients may be asymptomatic or minor symptoms like fatigue, malaise, anorexia, mild hepatomegaly, and persistent intermittent jaundice. So the jaundice will not maybe either persistent or it may be intermittent, that is appearing after some time, and there's also mild hepatomegaly. The extrahepatic manifestations are more common in hepatitis B virus, which will include arthralgias, arthritis, glomerulonephritis, and polyarthritis nodosa. On investigation, the serum bilirubin may be normal or may be raised up to 10 milligrams per deciliter. The aminotransferases are mildly elevated, in which ALT will be more than AST. But in case of cirrhosis, this ratio will be reversed, that is AST will be more than ALT. The serum proteins either may be normal or there may be hypoalbuminemia and hyperglobinemia. Hypoalbuminemia, since the proteins are synthesized by the liver, whereas gamma globulin is synthesized by the B lymphocytes. Therefore, there is hypergamma-globinemia in severe cases. The prothrombin time is prolonged. The serological markers will include HBsAg, HBs antigen, which is hepatitis B surface antigen, which is the first marker to appear before the onset of symptoms. It indicates infectious state. Anti-HBsAg will appear after the disappearance of HBs antigen, and it is present in case of vaccination. So it is anti-HBs antibody. It is present after disappearance of antigen, and it is present even after vaccination. Protection, it is protective function, it is protective in function, and it persists in life, for life. Anti-HBC antibody. So as we know that the HBC antigen, it is not secreted, whereas the HBC anti-HBC antibody is secreted. It may be either IgM or IgG type. IgM is the earliest antibody marker and it indicates recent infection, whereas IgG indicates remote infection. Hepatitis B, HBE antigen, it indicates infectivity or replication. Anti-HBE antibody, it is generally found in recovery phase. HBV DNA or DNA polymerase, it indicates acute viral replication and is also valuable in assessing the prognosis. So here is a graph on how these things rise. That is, HBs antigen will be the first marker to rise, and it will rise, it will increase and it will decrease. After the HBs AG disappears, the anti-HBs AB, that is the antibodies of HBs, will start appearing. The IgG anti-HBC antibody will be the first marker to rise, first antibody to rise, and it will increase and will become constant, will persist for life. The HBeAg will appear soon after the appearance of HBs antigen, and after the HBe antigen disappears, the anti-HBe antibody will start appearing. Also, the HBV DNA will be positive when all these antigens are also positive, which indicates active viral replication. Let's look at the treatment of chronic hepatitis B. The patients without cirrhosis can be treated on pegylated interferon alpha, tenofovir, or entecavir. With cirrhosis, pegylated interferon alpha is contraindicated. So first we'll see if the HBV DNA, that is the DNA, is positive, then we have to look at the values of this HBV DNA. If it is more than or equal to 2000 international units per ml or less than 2000 international units per ml. If it is more than 2000 international units per ml, it means there's active replication. And now we have to look at the values of ALT, which is the alanine aminotransferase. And in this, if it is normal, then we just have to monitor the patients for 3 to 6 months. If it is more than twice the upper limit of its value, these are the upper limits, and if it is more than twice the upper limit of its value, then we have to consider liver biopsy and treatment. Whereas if it is less than 2000 international units per ml, we have to look at the ALT. If it is normal, then we have to monitor for every 6 to 12 months. Whereas if it is increased to twice the normal, then again we have to consider liver biopsy and treatment. For the treatment, we have to use antiviral agents, which will include pegylated interferon 2 alpha, which will be injected 180 microgram once a week subcutaneously. It has a lot of side effects, therefore it is not used nowadays, such as hair loss, headache, depression, malaise, flu-like symptoms, bone marrow depression, and thrombocytopenia. The HIV patients will also respond poorly to this, and also it is not used in cirrhotic patients. It is contraindicated in cirrhotic patients. We can use entecavir and tenofovir, which is generally used nowadays. Entecavir will be used 0.5 to 1 milligram daily, whereas tenofovir can be used 25 milligram daily. It decreases the HBV DNA, therefore decreases the active replication. Lamivudine has increased rate of viral resistance, therefore it is not generally recommended nowadays. 100 milligram once daily till the HBeAg negative was the previously used dose. Adifovir is a nucleotide reverse transcriptase inhibitor, and it is used 10 milligram daily in lamivudine resistant cases. Telbivudine is 600 milligram once daily. It can be used and causes myopathy and neuropathy. The prognosis is generally the chronic hepatitis B can progress to cirrhosis and hepatocellular carcinoma if not treated adequately. So this was all about chronic hepatitis B. Thank you.